The organizers have titled this session Basics of Liver Transplantation, which means that they are trying to suggest to us that we stick to the basics. However, I would put it this way, that we will try and divide these 45 minutes roughly into two parts. The first is to look at some of the basic issues, but I think it's important and I think it's relevant to also talk about what's happening in India, because I think for the audience it is equally important to know where we are, what's happening. And Neelam, please join us on stage. I think I'm not going to introduce the panel once more. Most of them are known to you, except to say that what strikes me as interesting is that we have Girish from a very large cadaveric based liver transplant unit in the UK. We have Neelam, who comes from a very large living donor program in Delhi, Gangaram, and now Medanta in Medanta Medicity. Did I pronounce it right? Okay. And we have Ava and Nilesh from Mumbai, who are involved in perhaps a mixed program, a small program but a mixed program where we have done both living donor and cadaveric transplants. And Zaur Patankar, who is aspiring to do transplants, but who is one of the few pediatric surgeons who has actually trained in transplantation. So we have an interesting panel from various backgrounds who can give their own perspectives, and those may bring out some of the issues. I am starting off with the indications for transplant, and I put up biliary atresia as an example of a classic pediatric liver transplant indication. So Zaur, there is no doubt that most of Kasais fail. Do you have any doubt about that? Is there any most Kasai portoenterostomies fail?
Yeah,
is that statement correct?
Yeah, it's not the question if, it's just when they fail. They do fail. Yes.
Okay, most Kasai enterostomies fail, and so most children with biliary atresia at some stage will become candidates for transplantation. The question though is, when do you decide in a partially failed Kasai, not one of those who never improve, but a partially failed Kasai, which is I think the description for most biliary atresia children, that the Kasai has worked for some time and then they start struggling. So when do you decide that now that child is a transplant candidate?
If a Kasai is done well, say within the criteria for success would be if you have if you have operated them within 60 days, then long-term survival is better. So most of them would require beyond 10 years. They won't require in the first 10 years. Now your answer to your question is, depends on the sequelae. Is that they have this sequelae, and the most serious sequelae of biliary atresia is portal hypertension, long-term. So if the sequelae are not manageable or they're socially unacceptable, I would say you must consider this patient.
Is it a quality of life issue? Is that
absolutely.
The quality of life.
It's the morbidity.
So can you just, Neelam, can you explain what is that quality of life issue?
See, I think I just want to make things very simple. And when I started probably 12 years back, and I used to think about all those numbers and all, but practically what it boils down, I'll tell you. When you have a patient who's undergone Kasai's portoenterostomy, what are you chasing at? I'll be looking at the bilirubin, right? And if the bilirubin comes down and you're around 3-4, yes, I know I'm going to buy a good time for this patient and monitor. We've had patients who are less than 1 also. So that means even if they are cirrhotic with portal hypertension, I'm happy dealing with the portal hypertension and looking at all those issues. And the synthetic function will not go bad. Now, there's another scenario where within a couple of months, you will get to know the success within 2-3 months. It's not that, you just have to wait for the cholangitis attacks and get to know. And so the dictum is that we put them on prophylaxis for 6 months. The BCH, that's what I'd learned from, and I personally, unless the child did not have any attack, then I may be tempted to withdraw after 3-4 months.
Yes.
So if the bilirubin has not fallen down, you do not hesitate to tell the parents, this is a patient for transplant.
Right, but isn't there a logic, Girish?
And then you need to monitor the next two things,
right.
The albumin. Because the INR is not going to get affected. So it's the albumin I start chasing, and once I know the bilirubin is not settling and the albumin is not, then I put myself into the 4th gear to look into the nutrition. So then we are just trying to get time to finish up my vaccinations and to improve the nutrition to decide for transplant.
Yeah, but
That's
isn't there also a logic, Girish, that you allow them to grow for two reasons? Number one is that the bigger the child, the relatively easier the transplant. I'm talking now from a technical perspective. And also the fact that there are some children who will go up and down and who will later on improve, and they may just escape transplantation. So just give us that, some idea of that.
Yeah, I would agree with you that technically it is much easier to do although I don't do transplants, but I do count the sweat on my surgeon's forehead after they come out of the transplant, and it's technically easier to do a transplant when the child is a little bit older. I think
when do you list them in the UK?
Sorry?
When do you list them in the UK? Because you are listing.
I think
the living donor scenario, they have a parent and they would say go ahead.
Neelam has said all the right things, that if the child's albumin is low and despite adequate nutritional support, and that's the time that you will think about a listing for transplantation, because and as well as a deterioration in your bilirubin, because this child is unlikely to then go on and survive on the native liver, and you might end up in an acute situation which you want to avoid, especially because living related program for us is not well established.
Okay, so I'm going to move on. There's a lot of ground to cover. Metabolic disease, Girish, Neelam, what are the good indications amongst the metabolic list? There's a long list, but some of the good indications.
Yeah, the common metabolic diseases that I've been doing in India has been Wilson's disease. That's number one for us. If you want to call progressive familial intrahepatic cholestasis, that's the next one we've done. And we've just done a couple of tyrosiniemias. So these are the common ones. We don't do alpha-1 or anything. So it's Wilson's, PFICs and tyrosinemia for us.
Yeah, about any comment on Wilson's, in the sense, when do you transplant in Wilson's?
Yeah, I think Wilson's is one of the tricky areas. I would say a fairly decompensated Wilson's, as we understand, person coming with ascites, little high INR, may not really need a transplant if you start treatment early. And unlike other causes of cirrhosis, here you have time to wait and try out treatment. And we've had a fair number of Wilson's who are decompensated and who turn around. They take a time for the albumins to come up, for the INR to come down, but they turn around. There are criteria for transplanting Wilson's. The Wilson's coming with encephalopathy would usually need transplant. There are scores. There's a King's modified score for Wilson's in the fulminant setting. Incidentally, whenever a Wilson's comes with a fulminant liver failure, they're almost always cirrhotic. But there is a score which includes INR, bilirubin, albumin, WBC and AST, and based on that you decide transplant. So Wilson's, I think one has to be careful and not rush into a transplant.
Girish, this was your talk, acute liver failure. I was actually hoping that you would tell us now that, like we have these sacrosanct, almost rigid King's College criteria for adults, which have been validated fairly well. Do you now, you're saying that you don't have those criteria for children in acute liver failure?
I think we still follow those criteria in children.
Are they valid for children also? I
think they are valid for children, although we are in the process of changing those criteria slightly, because if you see the King's College criteria, it's on acetaminophen and non-acetaminophen poisoning, and in the non-acetaminophen we are going to include there was one major criteria and 3 minor criteria. We are now in the process of changing it through the liver advisory group, all the criteria, and have 4.
Okay, so we're not going to discuss, ask them to describe the King's College criteria.
Yeah,
they're in all the books. But the message you're saying that the same criteria presently apply to children.
The same criteria presently apply to children. What I'm trying to say is, do not go on the PELD score. The PELD score is not a good indicator for transplantation.
That's what
Can I just make a comment about metabolic disorders?
Yeah.
That the inherited group of metabolic disorders are the most difficult ones to transplant. We have found the urea cycle disorders and the glycogen storage diseases are even more difficult to transplant because they don't have portal hypertension.
Okay. I think, yeah, Neelam, sorry.
I just thought, the message should be clear to the audience. What regarding Abba was saying, the message is Wilson's in acute liver failure, you have to think of transplant always, because virtually there's 100% mortality, and Wilson's in encephalopathy, no way you'll be able to return. But what she was trying to say is a decompensated chronic, give them some time. So don't confuse that. Next time you see a patient acute liver failure in Wilson's, you should not think that she said wait for that. So that's the message that.
Okay, I have just put up something there which is phrase timing, in the sense we know that it is critical in liver transplant. Transplantation is not something that you offer to somebody who is about to die, except in the acute liver failure setting. So can you just summarize when anybody with chronic liver disease, children with chronic liver disease, when you say timing, can you give guidelines? Can you say start looking at it when the child is child B score, or the PELD score is X, or the MELD score is X? Can somebody give that information? Yeah, sure.
See, what I try to tell the pediatrician is look at the growth chart, and I say when the growth chart is going up, everything is hunky-donkey, that's good. And don't wait for the growth chart to start dipping. It's when the growth chart plateaus, especially on the background of liver illness. That's when you must start thinking and start referring the patients to a specialist center. So the pattern of reference is when it plateaus, not when it starts dipping. By the time it starts dipping, by the time he comes to us and working out, is probably too ill.
Okay, any comments on timing, Girish?
I think the timing already we have touched upon in biliary atresia, where the moment you find that the patient's albumin starts falling or the bilirubin is not coming down, the child may be 4 years old, or it may be just 6 months after the failed Kasai's. So ideally, perhaps you should wait for the child to be 10 or 12 kilos if it's a very small child, because the technical aspects will become much easier after the child is 10 kilos. Or as they said, the other standard criteria would be as the nutrition of the child starts suffering, and perhaps that you can determine from the growth chart itself.
Yeah, so I remember, Neelam, you were talking about this in meetings, that there is something called optimization of the child. Nutrition seems to be a huge issue, especially in the Indian scenario. So can you just tell the audience that when you prepare a child, because you prepare them in the planned manner for a living donor transplant, how do you optimize them?
Well, what happens is that the first thing is that we want to give them at least 120% of the RDA calories, and this 120% is calculated from the 50th centile of the ideal weight. And I have gone up to 150, 180 and 200 calories per that thing. So it depends how the child, and you cannot jump up in the calories. You have to, every 5th or 7th day, you have to increase it by 20%. So despite giving an adequate calories, either orally or sometimes you try to use the tube feeds, if you are not able to achieve results, then is the time I would say that though my target would be 8 to 10 kgs, if I'm not able to reach there, then I would want to prepone the transplant, because this child will now start deteriorating rather than improving. So that is what you need to decide. If you're able to nutritionally sustain that child, then yes, obviously we want to postpone the transplant. We want to get the vaccines and that.
So
but
nutrition impacts on the results of transplantation.
100%. It has been shown in all studies in children, the outcome of transplant. Nutrition plays an important factor, not only in the duration of stay in the hospital, the ICU stay, the cost, but also the outcome, in which the outcome is supposed to be 15 to 20% less in those people who have been malnourished as compared to that. So it has a very big impact.
Quick comments from Girish. If given a scenario of few weeks, would you do tube feeding? I mean, how do you rapidly, do you ever use TPN?
I think we use tube feeding quite regularly, and in fact what we do is we keep them on overnight tube feeds initially and bolus feeds during the day. The other thing that we do is, because it is easily available to us, is some of these children are jaundiced, and we give them MCT based feed, medium chain triglyceride based feeds, because those are the lipids which are easily absorbed from the bowel without the presence of without the need for bile acid in the bowel. So that's why we use the MCT based feeds, and I'm not sure whether they are easily available here or not.
We have up to 30%, beyond that we don't have. Even the trade names, I don't want to say, but though they call MCT feeds, they are just 10% and 30% we cannot go beyond.
Okay,
one more thing about optimization, she just alluded to that, is vaccinations. You take the opportunity to vaccinate the child, and we know that after transplant they cannot be given live vaccines. So those have to be completed.
Okay, going on to the next issue, the results of transplantation in children, and I think they have just now breaking down into two areas. One is the short term. So perhaps Nilesh, you can tell us What is it that is peculiar to pediatric transplantation? What are those complications which are perhaps higher than what you would see in adults?
I think it's a very sensitive issue, especially for our own team, because we have found that we need, apart from a good input from the surgical and hepatology side, there is a very important pediatric intensive care input required, especially for very small children, less than a year old or less than 2 years old. The problems of their ventilation, their lung issues, nutrition, all this is extremely important for us to get continuous information and cooperation and feedback from pediatric colleagues. So I think it's extremely important to have a well-trained pediatric intensive care person who is going to look, especially if the child is very small. So I think that's one point which will impact on short-term complications, especially in terms of how much the child has to be ventilated, how the child recovers after the operation the first 4 or 5 days, and in terms of the nutrition post-op. So I think these are the important issues for the short-term complications. Obviously there are surgical issues also, in which especially when you've done your biliary enteric anastomosis, there's a higher incidence of post-operative complications in biliary atresia patients who are undergoing. Because of previous surgery, adhesions, you can get bowel perforations, and you have to have a high index of suspicion, and some of these patients need re-exploration. But the message here is that even though they do need re-exploration, the long-term results, it doesn't really impact on the long-term results, which are actually very good.
I was hoping you talk something about the artery, because the artery is the big issue in children, the arterial complications. It's not a surgical audience, obviously we'll not in detail, but we must flag the issue that hepatic artery thrombosis is a huge problem. And I don't know, maybe we can say that there have been a lot of technical modification. Would you like to just...
Yeah, I mean, the incidence of arterial complications is almost 2 to 3 times that what you see in adult to adult living donor liver transplant. So I think a great deal of attention needs to be paid to doing the artery technically very well. And we have taken the help of microvascular surgeons at our center to ensure that the arterial complications are minimized in the post-operative period. But that's a very big issue, and you need to also do it well as have a very high index of suspicion in the post-operative period. And if there's any suspicion, you may need to do a CT or an arteriogram, or immediately rush the patient back to theatre and redo the anastomosis if required. The incidence is almost 15 to 20% in the pediatric age group, especially as the child grows below 2 years of age. And that was one of the reasons why arterial complications being high in less than 10 kilogram children, that you try to avoid a transplant before the child is 10 kilograms.
So the technical issues, although we don't want to go into this, is the fact that these are small vessels to anastomose the bile duct. So the technical complications are definitely more than... You want to add something, Neelam?
If you permit me, I just wanted to add, actually, the complications which you said 10 to 15 usually used to be earlier. For example, in our experience of 52 children, we've had just 1 hepatic artery thrombosis, which would mean just 2%, and I'm talking of less than 10 kgs. We have around 10 patients. So it was only 1 patient who developed sepsis, and that sepsis gave rise to hepatic artery thrombosis. And probably how we go about it, if I may say, we made a protocol where we are doing twice a day ultrasound Doppler on the first 5 days. It's just like a protocol, so you can't go wrong. A. B, we use intraoperatively heparin as well as heparin post-operatively. Yeah, so and that's what we just
so there are sort of strategies to reduce it. With 1 person, it's very good. We go to the long-term complications now, and Girish, you are now going to be seeing patients who are 4, 5, 8, 10 years down the line. So how are they doing? How do the children do in the long term?
I think overall, the current survival rates for liver transplantation are, we quote around 95% 1-year survival, we quote around 90% 5-year survival, and around 80% 10
So that's about 5-10% higher than adults.
That's
if you look at the figures.
5-10% higher than adults, because in a way we get boutique livers into inverted commas, because the adults usually don't get the boutique livers that are reserved for the pediatric population. That's one. The other long-term issues that we sometimes see in these children are, we have seen sometimes hepatic artery thrombosis as well occurring in the long term. So keeping a watch on them in the long term is important, and growth is the main issue.
Yeah, the quality of life. Again, I ask all of you. I mean, we've said this often, but it seems to me, at least from a very limited experience, the change in the quality of life in children is just dramatic.
Yeah, it's better than mine.
Tell us more on that. School and scholastic performance and...
Yeah. I think these children go to mainstream school. They do not need any additional support. Some of them can have problems with visual and spatial orientation, and that could be related to the tacrolimus, but I don't want to be that as a negative factor, because some of these children have been very unwell prior to transplantation.
But immunosuppression is lifelong, so Neelam, is that a problem? I mean, in the Indian scenario, compliance for immunosuppression.
See, actually, when you talk about quality of life, it's like, what are you comparing with? If you're comparing with a child who maybe visits a doctor once in 4 years, 5 years, yes, you would be different, because you need to do the blood test every month initially. Then after, like patients who are now 6 years on follow-up with me, they do blood test every 2 months or 2.5. So otherwise they're attending the normal schools, doing everything else. And only issue is sometimes in 2 patients we've had issue with compliance, and that has been disastrous. Both of them were adolescents, and unfortunately we lost both of them. Because one child, she came from a very poor economic status, and she went off to village and she didn't take it for 2 months. So this is the issue that has to be drilled into them, that this is a tablet which needs to be taken morning and evening. Are you sure you'll be able to take it?
Do they need to be isolated? In the sense, do they need to walk around with masks and or spacesuit kind of things, or do they need to be at home?
No, not really. I mean, only in the immediate post-op period when the immunosuppression is much higher, that we do not encourage them to go into crowded public places. But otherwise, not really, because that also has a lot of social stigma.
Can we also give a message, Nilesh?
The only thing from our limited experience is that they need to be educated also for reporting immediately if they develop any infectious complications, which may seem to them minor, even if they have upper respiratory tract infection. We have had one patient who was treated and developed a fungal sepsis in the lungs. So I think it's important to educate them that infections should be treated very quickly, and they should report to the transplant team if there's any even minor infection.
Yeah, I must just add, as Neelam said, in adolescence, I think that's a problem for any chronic disease in adolescence, be it Wilson's, Dr. Yacha alluded to, and celiac disease. They are all non-compliant. So that is a problem of adolescence. And we had this child who actually took up a microbiology course, and which we realized in the retrospect, and she developed fungal infection. I think that was a mistake. She shouldn't have taken a course like that. So I think when you are telling them about future, kind of
my last point on this slide, Girish has actually given the data that now that we have a history of 25-30 years across the world, we know that actually children in many ways will do better in the long term, and the long term survival, because some of the diseases that you are transplanting in children don't recur. So which are the diseases which may recur? I mean, biliary atresia doesn't recur, right?
Definitely not.
Okay.
But the diseases that recur, we see, are autoimmune liver disease. Wilson's disease also doesn't recur, and none of the metabolic diseases recur as such. But the main problem is autoimmune liver disease. And now what we are
sorry to interrupt. The reason to just flag this is that in adults, on the other hand, it seems that a majority of diseases actually do recur, although you can control them. Are we right? I mean, Hep B, Hep C, many of them do recur, but we control them. Where children, it's actually completely different. You said Wilson's can recur?
No, Wilson's never recurs. Sorry.
Okay, never recurs. Okay. Yeah.
See, in adults, obviously, the common causes are B, C, sclerosing cholangitis, and even NASH. So all these are going to recur. In children, what the disease is?
Forgot alcohol.
Right. In I'm assuming he'll not drink. So in children, the issues that I would say is, one is an autoimmune liver disease, because we've transplanted a couple of them, and you have to be very good in playing with the immunosuppression a little different. We would try to keep mycophenolate more often than in others. So your immunosuppression strategy is going to be different to prevent recurrence, and also NASH is something that you've got to be cautious with.
Okay.
Can I just mention that we have now seen, PFIC was one of the common one of the indications for liver transplantation.
PFIC. Okay.
Progressive familial intrahepatic cholestasis, okay. Which was initially called as Byler's disease. And now we've seen that PFIC type 1s do recur as well.
Okay, I just move on now to the sort of second half which I mentioned of my of today's discussion, because I think this is coming down to now practical issues. And as you know, in the last 3 years, since the last time we had this meeting, one of the changes that we have seen in India is that we have many more centers, many more transplants being done. But the fact is that most of them are, especially in children, but even in adults, most transplants are living donor transplant. And therefore, I think it's important to just start looking at some of these issues. So, this is just a slide listing out how a child can get a liver. So, you can have an entire liver from a pediatric cadaveric liver donor, that is a deceased donor. Very, very rare in India. I don't think it's still very common in the UK. Most children would still get a reduced size liver. Of course, you can get a part of the liver, and this can be either from an adult deceased donor or a cadaveric liver, which is reduced in size. So, you have a big liver from an adult donor, you cut it down, either you use both the parts or you use one part for the child. And of course, you can have a live donor from a parent, usually from a parent. Now, we have therefore a scenario, Nilesh, now where perhaps in a city like Mumbai, not so much in Delhi, you have the option of listing a child and using an adult cadaveric donor. On the other hand, you have the parents who are saying that, well, we are willing to donate. So, how would you now approach this?
Yeah, see, I think logistically for children, it still seems more feasible to offer living donor liver transplant, because the risk to the donor seems to be lower in terms of, because you have a...
I'm just going to stop you there. So, you said that the risk to the live donor for children is lower.
Yes, I think if you're going to do a left lateral segmentectomy, whatever documented data we have, the risk is slightly lower, at least in terms of the post-operative complications of liver failure, mortality, etc. You still have a fair amount of morbidity, and you must realize that, of course, but the overall risk is definitely lower for a adult to child living donor transplant as compared to adult to adult. The second thing is that when you do a cadaveric split liver transplant, where you use a left lateral segment for a child and the rest for an adult, the problem is logistics, and large units in the world are able to, because what you need to do, just imagine that if you have a liver which you have retrieved and you're going to cut it down into 2, you immediately need 3 teams. You need an experienced team which is going to cut down that liver into 2 halves without damaging either half, and then you need 2 teams to simultaneously do a child transplant in one theatre and an adult to adult transplant in the other theatre. So this is one way to do it. The solution to this, if you obviously do not have the logistics and if you placed your child on a cadaveric list, you can just do a reduced size. That means if you do not have the facilities to do 2 transplants at the same time, you can either export that liver and let somebody else do it, or you, if the child is first on the waiting list, use the left lateral segment of that cadaver and throw away the rest if it is not possible to use it simultaneously. So that would be the strategy for cadaver, which seems logistically a little nightmarish.
Yeah, I think the reason to bring up this point is that at least in 2 or 3 cities in India now, there is some cadaveric donation. So there is an option perhaps that is opening out. But largely, I think for children in India, living donor seems to be the way to go. The provocative question here is, perhaps Girish first you can respond that you don't do living donors. So you're beginning to do. I know your first living donor was done, but is it that when you start doing living donors, you will actually transplant them earlier and get better results? Neelam, do you feel that?
Thanks for asking that question. I personally feel maybe our results are much better than the international centers. Maybe because, see, when you give a living related donor, the liver is pretty healthy. So you don't face issues like primary non-function and, you know, the old livers and all those steatosis and etc. Because in a living related, you choose what, so maybe the outcome I feel personally is better in living related. I mean, I'm not trying to, I would obviously propose cadaveric transplants at any time, but, you know, just to say to that. And your timing of transplant is better from perspective of the patient.
Right. So except for the fact that that's an important fact, that there is a very, very small but definite risk to the donor in living donor transplant, I guess on all other fronts there can be a strong argument for living donor transplant, especially in children. Any comments on that, Girish?
Yeah, I mean, I think I would totally agree with it. Means, you know, sadly we have been, from the physician side, if I can say so, the living related program at Birmingham for quite a while, and I think we have achieved something now by doing our first transplant. But I have to say that not because you're chairing the session, but I have the deepest respect for my surgical colleagues who anastomose 3 millimeter portal veins.
Right.
Can't even find them.
Okay. This is just a slide just to share with you the limited experience that we have had. Just so this is how it has sort of played out for us, and this is just coming back to what I said some time back, that we have a mixed bag, and it's very obvious that majority of the pediatric transplants we've done are living donors, and it's the reason is that if we are listing an adult patient and we have any given time now 10 or 12 or 15 patients on our list, we would rather use a cadaveric liver for an adult patient, because living donors are usually possible, one of the parents or one of the uncles or a second degree relative for a child. The scenario in Delhi, which is a much bigger center, is that they have gone the living donor way, they have had success, and cadaveric donations are on relatively less. So I guess partly this is going to play out depending on which city you have. This just to finally go back to this issue for a minute, and perhaps Zahur can tell us, because you have trained in centers with large living donor experience in the East, and the East is where living donation has been first described, propagated, and with very good results. So can you tell us the truth on the risk to the donor?
Yeah, I think in the pediatric, as Nilesh rightly said, see, one is the parents, both the parents are willing donors. They come forward voluntarily. So that is a good thing. In adult to adult, you always have to convince them. Number two, when the option of deceased donor doesn't exist, and you put the figures to the relatives, and you tell them there's no option, literally we tell them that, see, the 24 hours to decide, 48 hours you have to take a call, otherwise this patient is going to die. Then they come forward, and they not only
that's in the acute setting.
Yeah,
I mean that's
in the acute setting.
But can you briefly just describe who, according to you, is a good donor for a child? In the sense, what are the 4 or 5 broad criteria you look for in a living donor?
I think across for living donor, whether it's adult or pediatric, there is just 3 criteria. One is the virology, that is the bloods. You know, they should be hepatitis serology should be negative. Number 2 is imaging. That is, we check the vascular imaging on the hepatic artery, the veins, and the hepatic veins. They should be suitable. And number 3 is psychology. You know, they have to undergo a psychiatric reference and find out they're not being coaxed into it, there's no pressure building on them, and that is the 3 important criteria I would feel.
Yeah, Nilesh,
I'll just add, you know, the biggest criteria actually is the BMI. It's important because this is the one thing that will make the same risk to that particular donor as compared to when you talk about living donor liver transplant. So apart from the fact that there's very low risk of liver failure because you're taking very little liver, the only issue is the BMI, and therefore the risk of pulmonary embolism in that donor and the risk that the liver may be more steatotic. So I think it's extremely important to have a parent who's young, doesn't have any medical illnesses, is usually between the ages of 18 to 45, and well, I'm talking about usually small children. So for adult to adult, you can take it as, I mean, usually you will not get a father who's more than 45 or 50 if there's a 5-year-old child to be transplanted. So no medical illnesses, and liver function tests and blood tests and ultrasound being normal. I think these are the basic criteria, and obviously they have to be of the same blood group.
Yeah, I think the BMI issue, in other words, the fatty livers, fatty liver doesn't seem to be that uncommon a disease in India, and not necessarily just looking at BMI, but also the metabolic syndrome, centripetal obesity. So I think a hard look at the liver to be sure that it's not fatty. Neelam, you want to say something on that?
Yeah, actually I absolutely endorse and all that. And just as you said, besides the BMI, what we actually go is for the LAI. We go for the fatty liver, irrespective, you may not be very obese, but so if the LAI is, we prefer to be more than 6. LAI is just, you know, you get it in a minute. A plain CT scan will tell you what is the fat content in the liver. So if it is more than 6, we are very happy. If it is between 1 to 6, we would rather like to do a biopsy and refuse anyone who is more than 20%.
Okay, there are 2 questions put up in this slide. I know they are very loaded, a bit rhetorical, complex, but I think it's important that we do discuss this for a few minutes. How do we make it cost effective? The other way of asking this question could be, how do we bring down the cost? Because it's very, very clear right now that you are not able to offer it even to 1% of the population. So how are you going to make this more available in the future? Many of those solutions are beyond our control, but what do you as teams feel could be done to make it more accessible? So Abha, Nilesh, Neelam, even Girish can give his views.
I think in our
There's no NHS
it's
here,
a difficult question to answer, as you said, and each one will have to sort of come up with their own unique solutions. But what has helped us in the past is actually mobilizing money for a patient from the public, because public seems to be very keen to contribute to a child's welfare compared to an adult's welfare. So whenever we have tried to, we haven't actually done it ourselves, if the patient has tried to advertise and try to mobilize money from the public, it has been very forthcoming. So I think that is maybe an unusual or a silly way to go about it, but perhaps that is something that can strike an emotional chord amongst the public and try to mobilize funds from there.
Yeah.
Yeah, I think we discussed that in the morning, setting up some support groups and foundations which will help. Of course, from our side, we have tried to keep costs low by cutting down the investigations, not doing unnecessary investigations, constantly looking at the clinical picture, not biopsying them as often, unless we are sure that we are going to get an answer on the biopsy. So I think we try to cut down. And now, unlike in the past, the cost of immunosuppression has come down. With more and more Indian companies making immunosuppressive drugs, the costs have actually come down.
Yeah, so the long-term cost is also an issue, right, Neelam? So it's not just the transplant cost, but the long-term cost.
See now, if I can add to both of them, how to cut down the cost, as I think more governments setups do have to come and take this, all said and done. I have a feeling that in the next 10 years you would find a lot of centers coming over for liver transplant, and the numbers are going to be really booming. I mean, we're all going to see that. It took us 10 years in the private sector, and we are doing we do around 25 a month transplants, cross 600 transplants. So once the government setup comes up, automatically the cost is going to get 50%. And then there's going to be so much of competition around that everybody will have to give, and then the confidence in everyone will increase. And like now we ask for very less tests, as she said. And but initially probably